So hello and welcome everybody. It's my pleasure to start this session. My name is Gavin Perkins and I'm the Director of Guidelines and ILCOR for the European Resuscitation Council. This is the first of a series of sessions that we're going to enjoy together over the course of the next 3 days, looking at the new draft European Resuscitation Council guidelines. Before the session kicks off with our 4 outstanding speakers for today's session, I'd just like to take you for a moment or two to the European Resuscitation Council's website in order to look at the European Resuscitation Council guidelines. So if you just bear with me for a moment. So this is the European Resuscitation Council homepage, erc.edu. So if you go to the web page and scroll down to the bottom, then you will be able to find the link European Resuscitation Guidelines for public comment. If you click on that link, then it will take you to the European Resuscitation Council guidelines for comment, where you can click on each of the individual guidelines in order to view the care conflicts of interest and to also look at the guideline content. We've changed the style this year for the European Resuscitation Council guidelines so that they're now presented to you initially with concise guidelines for clinical practice. So these are the key recommendations from the European Resuscitation Council that are available for the reader to immediately come and see what our recommendations are. And then the second section of our guidelines provides the rationale, so the so-called evidence informing the guidelines. When you've had an opportunity to review the guidelines, we very much welcome your feedback on the guidelines, positive or negative, and wherever possible, evidence-based. In order to help guide and improve the European Resuscitation Council guidelines. You can provide feedback. The website provides the place, click here for the survey, and that will then open a SurveyMonkey homepage that will allow you to select the guideline that you wish to comment on, provide your details, background, and any relevant conflict of interest, and then to provide your specific feedback. And it will be really helpful for those of us that will be reviewing the guidelines to provide the line number so that it's absolutely clear to us which parts of the guidelines you're commenting on. So I hope very much you enjoy this session. We've got a terrific team of speakers lined up, and who better to kick us off with this session than Federico Semeraro. Thank you.
Thank you, Gavin, for a kind invitation to Manchester, virtual Manchester. Hello to everybody. It's a real pleasure to be with you today. I share my screen very quickly. And I'm Federico Semeraro. I'm a consultant in anesthesia and intensive care from Maggiore Hospital, Bologna. And this is my conflict of interest. As you know, mainly I'm a Star Wars and Star Trek addict. Sorry for that. First of all, I'm very grateful to ERC Executive Committee to accept this amazing dream team as a writing group. So I'm very grateful to work together with these amazing friends. And a special thanks to Gavin and Jerry. I'm totally sure they have a special gift. I have suspicious, in my opinion, they are time travelers. They decide to release guidelines exactly during the Back to the Future Day. So let's start. The System Saving Life guideline describes numerous and important factors that can globally improve the management of cardiac arrest patients, not as a single intervention, but as a system-level approach. The aim is to provide evidence-informed best practice guidance as a system in out-of-hospital and in-hospital cardiac arrest system. The target group is government, manager of a health and education system, healthcare professional, teachers, students, and lay people. And the concept behind the system saving life approach, cardiac arrest, is to emphasize the connection between the different actors involved in the chain of survival. For example, citizen are evolved through cardiac arrest awareness. They may be engaged by apps as a first responder. The system-saving life concept emphasizes the interconnection between community and EMS and should be implemented in each European community. A lot of topics, several topics included, from the young students who learn CPR at school to a citizen who receive a cardiac arrest alert through their mobile phone and is willing to start CPR NAD on the scene, to the EMS team that continues advanced treatment to stabilize and transport the patient for post-resuscitation care in high-performance hospital. System saving life, everyone and everything is an important link to survival, and we are moving from the classical 4-link chain of survival to a multitude of links in the new system saving life concept. Every single step in this complex system is important. I would like to invite you to read in practical some very nice topics. Low resource setting, very new, based on ILCOR scoping review by Sebastian and Kuhn-Monsieur, and a ERC successful story. We need to be proud of all these people reached in the last 7 years through Europe with the support of every National Resuscitation Council, and in the world with the collaboration of International Council and ILCOR, from European Heart Day to World Start Heart. Thank you to Mario, Sandy, and Bern for this amazing event. And again, another very nice ERC success story. I'm so proud to be part of the team of Kids Save Life campaign. COVID-19 unfortunately recently affected Kids Save Life campaign implementation, but we believe that kids learn much better than adults the new rules of the game for CPR training in COVID area. We updated the map, European map of CPR education 2020, and the map slowly became red and pink, and we are very proud of it. Finally, last but not least, the social media and smartphone apps, sci-fi technology become finally real. In line with ILCOR, the ERC recommended that all first responders in close proximity to a suspected out of hospital should be notified by dispatch center through an alerting system implemented with a smartphone app or a text message to improve bystander CPR, to reduce the time to first compression and shock delivery, and to improve survival with good neurological recovery. That's all, folks. A very quick fly of the rainbow of system saving life. These guidelines now are open for public comment. Please give us your feedback on ERC website and help us to share the concept of system life saving life when posting some article, photo, video, or news. Use always hashtag system saving life. My take home message: live long and prosper, and wash your hands. You must. May the force be with you always. Thank you.
So many congratulations, Federico. That was an excellent talk and overview. And to just remind people that are participating in this section that the full recording of your talk is available lower down on the platform screen. So if people subsequently want to delve into the detail of the System Saving Lives chapter, as well as reading the guidelines, they can watch your short video on that. That's also available on the ERC conference website. So if people have questions that they want to pose to Federico, then the place to do that is on the Slido question tab that again is available on the European Resuscitation Council conference website. So if people have questions that they want to pose to Federico, please ask them there. I guess while people are thinking about that, the question I had on, again, a really insightful talk was full implementation of the System Saving Life guidelines. What aspiration, do we see, or what impact can the full and successful implementation of System Saving Lives, have on people that sustain a cardiac arrest? What's a realistic survival rate?
I can say, I am a visionary. Maybe we can increase it with a double or triple effect on every system. I can say that COVID-19 affected obviously the system, but I think the system can saving life, and system can saving life against COVID-19 at the moment. So I hope double or triple effect on the survival.
Okay, no, that's great. And looking at the list of interventions that you've evaluated in the System Saving Lives program, if places didn't have any of those systems, what would be the ones that you'd recommend they do first? I guess which are the ones that are likely to have the biggest impact?
If I can say the easy things to implement is obviously cardiac arrest awareness as a World Startup Day and Kids Save Life campaign. But in terms of impact, I think we have to work in first responder engagement technology and on dispatch. Maybe Teresa mentioned about it after. I think we need to work hard on first responder, dispatch, CPR, and the lay engagement with the use of technology.
Okay, great. Now some questions are coming through on Slido. So this is from Wolfgang Hansel. Why do we teach Kids Saves Lives check, call, compress, and not call, compress, defibrillate?
The message with kids, we have to use a very simple message. So we have to adapt the terms, the scientific terms, in a easy way for the kids. So check, call, compress is a easy way to teach and learn for kids the sense of CPR.
Okay, and another question from Wolfgang is, why does the Kids Save Lives campaign start at the age of 12? In Austria, they've got experience of training tens of thousands of pupils from the age of 8.
You have to set a period of time. So at 12, you have the power to have the strength to have a very good CPR. But obviously, as you remember, a breathtaking picnic for the primary school, you can teach and learn also in the primary school to call for help. And so you can absolutely start much earlier, but at age of 12, you have the strength to run a very good CPR. This is the reason. Great.
So start as early as is practical, but recognize that it may not be until children reach the age of 12 that they have the physical strength to be able to do so. We have a comment from Bucharest talking about their out-of-hospital cardiac arrest protocol. It doesn't provide more details, but it's saying it's having a tremendous impact at a system level. So that's all great to hear. I'm very conscious of the time, Federico. So I think that we've probably reached the point that I should hand over to my co-chair now in order to introduce the next speaker. But I'd like to extend my cordial congratulations to you for an outstanding talk. Well done.
Thank you very much indeed.
Thank you, Gavin. I'm Jas Saur. I'm the program chair for this conference, and gives me great pleasure to introduce Teresa Olasvigen from Norway. She's the ERC BLS chair and the ILCOR BLS chair. While she's getting ready, remember you can ask questions on the platform. You can vote up questions with the thumbs up arrow. So start commenting, start asking questions, and we'll take them at the end of her brief talk. And also, if you scroll down, you can watch a longer version of this talk. Thank you, Teresa.
Thank you, Jas. So this is going to be a very quick and dirty rundown of the 2020 BLS guidelines, condensing the 10-minute presentation that you can find on the virtual platform to a 3-minute presentation. So the 2020 BLS guidelines are based on 22 systematic reviews, 5 scoping reviews, and evidence updates performed by ILCOR, as well as the independent work of the BLS writing group within the ERC, filling in all the gaps so that we could create a whole CPR guideline from start to finish. So I think with the 2 minutes I have left, I would like to share 3 updated recommendations. Now, the first one is recognition of cardiac arrest. Now, our basic recommendation remains that cardiac arrest should be recognized in anyone who is unresponsive and not breathing normally. Now, this definition is flawed, as every unresponsive person not breathing completely normally is not in cardiac arrest. Still, we still have a lot of studies that report agonal breathing and seizures to be main barriers, and we're still missing a lot of cardiac arrests. So in the 2020 guidelines, we've tried to be really clear, adding recommendations to not confuse agonal breathing and seizure-like movements with signs of life. Can I have the next slide, please? So the second one, calling for help. Now, calling for help is still the first thing you do as a rescuer. But in many cases, the caller can put on our mobile phone on speaker or use a hands-free option so that calling for help and starting CPR can happen simultaneously. And I think this really needs to go into the way that we teach CPR. Next one. And last but not least, safety. I think we all feel pretty different about rescuer safety than we did a year ago. So just to reiterate, rescuer safety first, PPE before CPR, and compression only is a good option in the BLS setting when there's risk of infection. So last slide. To sum it all up, there are relatively few changes to the core components of basic life support, but emergency medical dispatch is again highlighted as a huge resource for the BLS provider. And I think the role of emergency medical dispatch is probably only going to grow and get bigger with new emerging technologies. Okay, that was it. Questions?
Thank you, Teresa. I'm looking on the live stream, so please do get your questions in. So I've got a question which you may have mentioned briefly in that, so we're recommending if anybody's unresponsive, not breathing normally, having a short seizure, for calling the EMS and starting chest compressions. Is it a problem if the person hasn't had a cardiac arrest to do that?
I think it's a relatively small problem. I think if you misunderstand and you start CPR on someone not in cardiac arrest, they're likely to tell you to stop. And I think it's there's not a lot of harm done. I think the potential harm of not recognizing someone in cardiac arrest is so much bigger that we really do want to stress erring on the side of caution and starting CPR whenever you're in doubt.
Okay, and I was going to ask one more question while I'm looking at the screen. Are you happy that anybody just goes and gets an AED, switches it on and starts to use it? Or do you think, I know it's a bit overlapping with the training, but can they just get on and use the AED without training?
Well, I think they can. We did a systematic review, really looked for all available science to see, what kind of injuries and complications have been reported. And AEDs have been in use for many, many years, and there is very, very little documented evidence that of a lot of harm. So I feel like we can be pretty confident in saying that AEDs are safe to use even for lay rescuers.
Thank you. We've got one question on here, and it's related to COVID, but I will ask you in terms of, do you think we should be recommending, covering the mouth and face for lay people when starting chest compressions?
So these recommendations, I mean, it's been some odd months, and I think we can be in situations where we feel like we're really in the thick of it, we're in areas with a lot of infection, and that it's reasonable to assume that coming across someone with a cardiac arrest, there is a real chance that they might have COVID, and in that situation, I don't really think there's any harm in covering the mouth to try to limit the aerosols that might be generated. But it's I think these recommendations really vary from what situation we're in and from region to region and country to country. And I guess the main point is just to follow the guidance where you are.
Okay, thank you. There's lots of questions coming in, so we may take some later on, Teresa. Just remember, if there's anything in the guidelines that you're not happy with, you can go to the ERC website and comment on those by feeding back, and all feedback will be considered, and the guideline drafts and for the final guidelines. I'm going to hand back over to Gavin to introduce our next speaker. Gavin.
So thank you very much, Jazz. That's much appreciated, and thank you very much, Teresa, again for an outstanding talk there. So just as a reminder to people, if you want to pose questions in relation to these talks, then please use the Slido app in the side of the presentation. You can also review fuller versions of these talks and presentations if you scroll down the European Resuscitation Council virtual website. I've noticed in the chat that some people have been making suggestions. Why didn't you do this in the guidelines? Why didn't you include that in the guidelines? That's absolutely the sort of feedback that we want to be receiving at the European Resuscitation Council, so that our guidelines that truly, serve our community and serve the evidence base. And so where people have those views and opinions, please do submit them via the ERC website, erc.edu. Scroll down the screen and then go to the relevant guidelines and send us the written feedback. I'm going to briefly ask our conference coordinator or chair that we do have a poll available at the moment on the Slido, so that can be accessed by clicking the right-hand side. I don't know if our chair, Patrick, is in a position to reveal the answers to the poll prior to Therese doing her presentation. I shall pause for a moment to see if that happens, and if not, then I'd just direct everybody to not only adding their questions into Slido, but also answering the question in the poll there. So I can see that there's 465 responses at the moment, and I think that these will be revealed to us all towards the end of the session. So without further ado, I'm going to hand over to our next speaker, Teresa Dar, who's going to be talking about the Adult Advanced Life Support Guidelines. Very much looking forward to your talk. Thank you.
Thanks. So you should be able to see my screen now. Are you doing that? Good. So I have the honor to present the Advanced Life Support Draft Guidelines. And this is my conflict of interests, and I have to thank the whole writing group. They've been doing a hard work. So doing the hard work, now it's up to you to really, as everybody say, are they useful? If they aren't, you should give us feedback on that, because they should be bullet points for you to go to practice and use. So this is the current guideline and a new draft ASS. I know the text is small and I will talk you through it. In the end, I would say that we moved some boxes. Here, we try to focus on the next layout to circle and what you should do around it. So if you summarize this, there's nothing really new from a medical perspective, but there is other things that we highlight on. However, there are things that are not new, but some are controversial to keep. One of them is adrenaline. As Gavin already said in the Peter Safar lecture, many of you have seen the paramedic trial. Many of you have read it and summarized it like this summary I found on the internet. In one line, it restarts the heart, but doesn't do good for the brain. That's one way of seeing that trial. And there is a systematic review done on more trials that has been done on this topic. And when you look at the meta-analysis of that, you will see that adrenaline comes with ROSC, with survival to hospital admission and survival to hospital discharge. And that's why it is in the guidelines. So next, the airway. The airway is always a hot topic. And I think that's because there's a lot of tools in here. The problem with the airway is whatever gets air in works. There's a nice review behind it. Read it. The third thing is we recommend IV access before IO. There is a nice talk by Jerry Nolan tomorrow, and you can see his video about that. And I don't want to spoil that video, so look at the video and see what it says about it and why we recommend it like that. There's also another topic tomorrow about ultrasound, and yeah, I just have to say, well, it's not so useful yet, but listen to the talk tomorrow and you will see why. There's also more algorithms, the tachycardia and the bradycardia algorithm, and you can read them. And what I want to stress with this one is that we separate tachycardia based on if the patient is stable or unstable. If they're unstable, we need to fix it quickly. Otherwise, we have time to talk. And I think that's a short summary of the guidelines. So please go in and answer the poll on the adrenaline question and take the opportunity to comment upon the guidelines online. And I think I'll stop there.
So thank you very much for, again, a terrific presentation. We can open this session for questions. And again, if people can use the Slido facility to assist with that. I wondered, Therese, if you could elaborate a little more on your personal approach to the use of ultrasound in cardiac arrest. Where do you see it fitting in your practice? And who should be using it?
I think this is very important because as an emergency physician, we use ultrasound a lot. And I think what you can do is to find a tamponade. That would be good to find very early and quickly. Otherwise, it's really hard to know what to do with it. I think that sometimes we use it to see contractility, but then you have to repeat it and repeat it again. And then you might use it as one of the key when you want to stop CPR or want to do more investigations. That's what I would do with ultrasound. I wouldn't use it for tension pneumothorax. I would treat it instead. Also as pulmonary embolism, I wouldn't use it there because looking at the heart during CPR is very tricky. So I would use it for tamponade. That's it.
Okay, and I mean, ultrasounds are now available fairly widely in both the hospital and pre-hospital setting. Should anyone pick up an ultrasound probe and start looking for cardiac tamponades in all cardiac arrests? So
I think we shouldn't be so afraid of ultrasound. I think it's here to stay. You just have to learn how to use it. So I think you could do that, but you have to talk to someone else. If you're not experienced with ultrasound, it's like starting to use a stethoscope. You have to discuss your findings with someone before you act upon them. And you cannot take away the things we know have evidence, like the compressions and the drugs and whatever we do. So you can't do it instead of something else. But if you can add it and do it and learn why we know better, that's fine.
Okay, great. So we've got some questions coming in. We've had two questions coming in relation to adrenaline. The first is whether you should stop using adrenaline when there's an increase in end-tidal CO2.
Oh, interesting. I think maybe some of you who are online can answer this question.
Yeah, I'm happy to comment on that, Gavin, in that at the moment we are recommending end-tidal CO2 has a role, waveform capnography, to identify ROSC, but you'd have to see a significant rise in end-tidal CO2 during the 2-minute period of CPR. So if you're using capnography and it was in kilopascals, maybe 1.5 to 4, or a big jump, as opposed to as opposed to a tiny jump. So in an ALS setting, if you are using capnography, it's something that you could consider if you think the patient's got ROSC, to withhold the adrenaline.
Okay, great. And perhaps one final question is in relation to the timing and the dose of amiodarone following synchronized shocks.
Sorry again, what was the question?
So there's a question in the chat asking what the guidance is in relation to the use of amiodarone following synchronized shocks.
I think it's no changes from last time, so it's after the 3rd and 5th shock.
Okay, that's great.
Yeah.
Okay, I've got an eye on the time, and I think there will be an opportunity to come back to the panel again. A reminder to people, and I'm not going to announce the results of the poll at this point, but once you've voted, then the poll results will become available to you, and we'll maybe return to that at the end of the session. But there is an open question in relation to adrenaline that people can provide their feedback. Great. I'm going to hand back to my co-chair, Jazz Saw, who's going to introduce the next speaker.
Thank you, Gavin. Our next speaker is Jerry Nolan, who's the chair of ERC, and he also led the group that wrote the post-resuscitation care draft guidelines. So thank you, Jerry. And while he's setting up, remember to ask questions, and you can look at the full longer lecture on the website, and you can also comment on the guidelines on the website. Thank you, Jerry.
Thanks very much, Jazz. So this is a very, very quick run through. I'm not going to be covering the whole of this section. You can see that attempted, at least in my lecture, which is at the bottom of the session down here. So the important thing to say is that this is a collaboration between the European Resuscitation Council and the European Society of Intensive Care Medicine, as it was in 2015. And I would like to thank all my co-authors in this collaboration, particularly Claudia Sandroni, who really was co-lead with me for the European Society of Intensive Care Medicine. It really is a huge topic, and I've just listed really some of the topics that we've covered within this section of the draft guidelines. And I encourage you to go and read those and look at them in detail, because what I'm going to just cover in these slides is only just going to touch on it, really. What I would say overall is I think that we've gone a lot more towards trying to find true evidence base to what we do in post-resuscitation care. And so some of this is quite complex. This is the algorithm. At least the draft algorithm, it's not massively different from the 2015 version, but as you can see, we've got these three domains, the immediate treatment, diagnosis, and then optimizing recovery down here. Most of the intensive care stuff is focused at the bottom, but of course, post-resuscitation care starts from the moment that the person achieves return of spontaneous circulation. So this could even be pre-hospital, for example, or it could be even on a hospital ward. You can see this algorithm in more detail in the full lecture. We discuss within the guidelines a whole range of hemodynamic targets, as you can see in this picture, and thanks to Marcus Griffiths for providing this. And you can see here some of the ventilation, so both oxygenation and ventilation targets that we're suggesting here. They're largely similar to 2015, I think, both the hemodynamic and ventilation targets, but there's an awful lot more data now coming out on this. And it may be that we are in a position to change things, perhaps in the near future, with some of these studies that are evolving. I think the area that's potentially the biggest amount of science, at least with some change, is around prognostication in patients that remain comatose after cardiac arrest. And this is a systematic review that's just been published very recently in Intensive Care Medicine. It's an enormous effort on behalf, particularly of Claudio Sandroni and his team. And you can see included in this is 94 studies of 30,000 patients. I suspect it might set a world record for the number of pages of an article published in Intensive Care Medicine. And just to sort of pull that all together in a summary slide, really, this is the revised prognostication algorithm. Again, I thoroughly recommend you go and look at that. There are some changes. The key thing is that it's actually, despite what I've just said about all the evidence, this is actually a simplified algorithm. And so we've now suggested that if the patient qualifies for this, and the important thing is that they have a Glasgow motor score of 3 or less, greater than 72 hours, and without confounders. And I won't go into all the details, but obviously the number one thing there is sedation. Of course, you need to be in the absence of sedation. We're now looking for at least 2 of these various factors down here that are all much more closely defined now as predicting a likely poor outcome, as you can see. And that, I think, is all I was going to show you from just really snippets from the presentation that I've made, which is online. And I'll hand back to our chairs. Thank you.
Thank you, Jerry. I'll start with a quick question. Neuroprognostication, so the patient's comatose on the ICU. How long should you wait before you decide to withdraw life support?
Well, I think generally speaking, unless there are overriding factors, we are still suggesting at least 72 hours. And that's on the basis of all the evidence that we've got at the moment. I have to say the group had a lot of discussion about whether to take that out to as far as 96 hours, but decided to stick with the 72. Having said that, in practice, and certainly in my clinical experience, I would say that in most cases, it's very rare actually to prognosticate and then withdraw life-sustaining treatment, probably for 4, 5, or even more days. And I suspect many of us will be experiencing situations where we're going out as long as a week in some cases, because of course that algorithm, there are quite a significant proportion of patients that don't hit any of the combination of those two factors. And so the advice there is to wait and continue to reevaluate.
Okay. Can you just clarify the target temperature? What target do we recommend? And
okay, so this,
at that point.
Yeah, this is always controversial, huge amount of debate, but it's safe to say it's unchanged from the 2015 recommendations, which is a constant temperature somewhere between, in fact, 32 and 36 is the recommendations, but it's a constant temperature for at least 24 hours. The reality is some form of temperature control should be used for up to 72 hours, because even when you rewarm to normothermia, every effort should be made to prevent pyrexia up until that 72-hour mark. And that's pretty well unchanged. Now, of course, we are awaiting the results of the TTM2 trial, which we're expecting hopefully to be presented sometime in around March, which coincides, of course, very closely with when we're hoping to finalize and publish our guidelines. So we're going to have to discuss how we deal with the results of TTM2. And I suspect it may lead to modifications of our guidelines if there's a reason to change them.
Can you just clarify the 32 to 36 recommendation? Because I think some people think it means keep it between those two, but that's not.
Yeah, no, you're right, Jazz. It causes confusion. The word that I think I did say it, constant temperature. So the typical thing is for units to either go for a 33 degrees C target, and there's a whole group of people that believe that that's the important target. And then there's a significant number of experts who would prefer to use 36. So I think the vast majority are tending to go either 33 or 36. But strictly speaking, the evidence really is somewhere in the range of 32 to 36, and that's based on the randomized clinical trials that have been done so far.
This is clearly a hot topic, lots on the thread. So you could type some answers and comments on the thread, Jerry, because I'm going to hand back to Gavin for the next speaker. Thank you.
Yeah, it's a pleasure. Thanks.
So thank you very much, Jazz, and thank you, Jerry, for a great talk. So the last in our series of talks is Carsten Lott, who's going to be talking about resuscitation in special circumstances. Just as a reminder to the audience, the full talk is available on the ERC virtual platform if you scroll down from where you're watching this, and we're welcoming comments on the guidelines via the ERC website, erc.edu. Carsten, over to you. Very much looking forward to hearing your insights into resuscitation in special circumstances.
Yeah, so thank you very much, Gavin. And I want to start with a very big thank you to especially you, Gavin, and the Guideline Steering Group. This has not been said as far because I feel that there are two really relevant ideas behind the whole thing that are totally new and that are really helpful in our whole guideline process. Number one is the split in the guidelines. So we have the concise guidelines for clinical practice right in front, and this is what people out there need. This is what we all need to work and to take on board. And on the other hand, I feel it's an excellent idea to kind of have that draft guidelines to clearly demonstrate that we want to set up common guidelines for everybody out there, and not just the things we thought in our rooms and our discussions. So I'm really looking forward to receiving all your comments on the special circumstances chapter and to modify it accordingly. Can I have the next slide, please? So I've been really happy when I was named to chair the writing group, to coordinate the writing group in special circumstances. And then we started working, and I noticed that this is really a very special chapter, that it has a lot of different things in and a lot of topics to discuss. So I'm thankful, I'm grateful to the whole writing group I had, to that expert group that supported me in the chapter. We only had 4 ILCOR costas and 2 ILCOR evidence updates, and all the rest is done by individual systematic reviews, scoping reviews, and evidence updates. And the next one, please. We mainly focus on management strategies. Patrick, can I have the next? Yeah, on management strategies in our chapter. So if it's not one back. So if it's not stated different, please stay with what you have seen in the ALS chapter, ABCDE for patients not in cardiac arrest, and the ALS algorithm for patients in cardiac arrest. Most important, and this accounts for most of the special circumstances, treat the reversible causes in the special circumstances. Next one, please. So we have 3 big subsections in our chapter. We did not change that from the previous chapter. We're talking about special patient groups, and they comprise asthma COPD patients, neurological patients, obese patients, and pregnant patients. And there's not much new in them. You can get the details from the guideline chapter. Next one, please. Next one is the special causes section. And as you can see, we had a lot of discussion before getting into the chapter structure if we should change the structure for H's and for T's, but we kept the for H's and the for T's. In hypoxia, there's not so much new. Hypovolemia has a clear focus on 3 subsections: anaphylaxia, sepsis, and trauma. And we have, in cooperation with the UK guideline, a new section, hyperkalemia and electrolytes. We have something new in hypo and hypothermia, especially in the prognostication part. In thrombosis, we added the chapter on cardiac thrombosis. Cardiac tamponade and tension pneumothorax remained unchanged. With toxic agents, we have a very new chapter with detailed information to specific toxic agents that will be available as a supplement once we publish our guidelines. Next one, please. And finally, we have the special settings. They focus on healthcare facilities. We have the cath lab, we have the operation room in there. We have a part on in-flight cardiac arrest in the helicopter system and in air ambulances. We cover cruise ships, and we kept sports, drowning, and mass casualties on board. And last one, please. So overall, management strategies we describe in our chapter, they cover ABCDE and the ALS algorithms, but we focus also on prioritization of the reversible causes when necessary, and we describe eventually modifications needed in the advanced life support algorithm. Many thanks.
Thank you very much, Carsten, for a great talk. So I've seen a number of questions coming in on the question facility. But perhaps before we start those, we heard in the advanced life support session around the potential role of ultrasound for the diagnosis of cardiac tamponade. What guidance exists in the special circumstances section in relation to if you've identified a cardiac tamponade, what action people should be taking?
Yes, as you know, we do not have that much evidence behind the use of ultrasound during cardiac arrest. Nevertheless, we felt it is important to use for many of our reversible causes to get it in. You can either diagnose a problem like cardiac tamponade, and on the other hand, you can guide the management of that reversible cause. Only thing you need to clearly take into account is you need to take care for the time you use, for the no-flow time you have when using ultrasound in managing your patients. We did some workshop on that in the meantime, using it like we implemented defibrillation in our patients, so using a stop-start sequence and recording the ultrasound pictures or the ultrasound video and then interpreting them later on to get your findings without shortening the flow time for your patients.
Okay, so some of the questions in the chat include what is the place of Reboa during resuscitation?
So we added, and as there's increasing evidence for that, we added Reboa to the management of trauma patients. So this will be part of the new algorithm, and this is what you can find in the guideline chapter.
Okay, and there's a further question on what is the role of ECMO, or would you consult a regional ECMO centre in the event that you have somebody in refractory shock following return of spontaneous circulation?
And refractory shock following the return of spontaneous circulation, yes, so in many of the reversible causes, ECMO or eCPR might be an option. So we mention it in several subsections of that chapter. So if you have the expertise and if you have the resources available, ECMO is going to play a role in the future in that situation.
Okay, that's great, Carsten. So I think we've got a few minutes left now, and there are quite a number of questions coming through now. So I wonder if we open it up to the wider group. So I've seen, Jerry Nolan, that there have been a number of further questions in relation to prognostication and targeted temperature management, and I wondered if in a moment you'd be able to comment with your insights on any of those. I've also seen that there's a question relating to the discontinuation of resuscitation, and I think in that context we'd refer people to the ethics session that will follow later in the conference. But if we could maybe go to Jerry Nolan for any comments in relation to the questions he's seen coming through.
Yeah, I've just been trying to scan. I had just tried to send an answer back. I think somebody was asking about, surely there are patients that achieve some of those prognosticators before 72 hours. I mean, of course, there are occasionally patients that have devastating hypoxic ischemic brain injury with obvious cerebral edema, for example, on the initial scans they come in, and then maybe NSE values are extremely high at 24, 48 hours. So those are rare exceptions, but I would urge real caution about trying to prognosticate with any certainty before that 72-hour mark, because most of these studies that are being done have been validated really at 72 hours. Some of them are even longer than that. And as I said, I think in my answer to Jazz earlier on, there was even some discussion within the group that it should be even 96 hours. So clearly when there is overwhelming evidence of severe hypoxic ischemic brain injury, then there are exceptions to that 72-hour principle, but they're unusual. I don't know if were there any other general themes coming through, Gavin, that you wanted me to address?
No, so I think that those were the two, the key themes were around, the decision to, discontinue resuscitation. I think I'd seen you'd answered some guidance in relation to the 32 to 36
yes.
question. I think Jazz Saul, my co-chair, has a comment he'd like to share with us.
I see there's a few comments about COVID, and I'd just like to say we've done some pre-recorded videos on COVID, which are in the library section of the conference platform. So you can go on there and see the Q&As about COVID, and you can also go and see the ERC COVID guidelines. And I think the key part that the take-home message on COVID is that if you think someone's got COVID or is high risk of COVID, part of the approach to resuscitation is the safety of the rescuer. And so the current guidelines for patients with COVID or at high risk of COVID do emphasize the need to protect the rescuer. And that means, and as things stand, the ERC feels that chest compressions, airway interventions are all potentially or actual aerosol generating procedures. And that's how the guidelines have gone forward. And because the incidence of COVID varies between different parts of Europe and even within countries, you do need to tailor those guidelines for where you're at. You know, if you're in a low COVID risk setting as against a high COVID risk setting. I'll stop there because I think we could spend a long time talking about COVID, but I'll let Gavin move on. Thank you.
Okay, no, thanks, Jazz, for sharing those insights with us. There's a great question that's coming in relation to ECMO and cardiac arrest centres that I think may actually bring in several of the component, you know, several of the different writing group chapters, potentially starting with the Advanced Life Support Group to remind us what the recommendations or guidance are in relation to the use of eCPR. And then if perhaps the System Saving Lives and Federico could come in to think about the implications that that guidance may have in terms of the provision of cardiac arrest centres and the ERC recommendations in that regard. So, Therese, would you guide people as to the European Resuscitation Council's recommendations in relation to eCPR?
Was it the question to me?
It was.
No. Oh, yeah. So I think there's a small chapter on eCPR, and I think what we know about eCPR that it's useful for some. I'm not sure that we know who will have the use yet. And there is a nice review, and I think it was in last week in Resuscitation New one prospective study from Japan also showing that it is cost effective also. So, and that will be my answer for now. Maybe some of you might add more. I think Carsten has some in his section also in special circumstances about ECMO.
Carsten.
Yes, so if I can jump in. So we kind of referred to the ILCO recommendation, and the ILCO RLS task force suggests that it may be considered as a rescue therapy for selected patients with cardiac arrest when the conventional CPR is failing, and it should take place in settings in which it can be implemented. So we need expert opinion, we need case reports and clinical experience. And this is what we have to support the use of the eCPR in a selected patient population.
Okay, and Federico, in terms of setting up your cardiac arrest system, what are the implications of eCPR in the systems concept?
Obviously, if we think that the cardiac arrest center is like a ideal virtual place where everything is at the top of the competence, ECMO can add some extra bullets in your rescue treatment. So if you have a very skilled competence on PCI, chest compression, quality CPR on the field, so ECMO can add some extra help for the system overall.
Great.
Gavin, I had a comment on ECMO in that clearly it's a high cost intervention. So in resources are limited in many settings. So even as someone who thinks it will help save lives in particular circumstances, if you have the same amount of money, it may have a much higher impact at the front end of the chain of survival in terms of early call for help, training people, AEDs. So in the big picture, it's a useful intervention, but there are lots of other more useful interventions you need to be doing first.
Great, thank you, Jazz. So going from eCPR to basic life support, we've had two questions that have caught my eye there. One is in relation to how you should check for breathing or check for signs of life during the COVID period when someone is suspected to have sustained an out of hospital cardiac arrest. So Therese Wallace-Vengen.
Sure. So I think we did have some specific instructions for that, and our thought is to be on the safe side, to look for breathing and to make sure that we're not recommending, putting your face over the nose and mouth to listen and feel for breathing, but to keep a distance and to just simply look for breathing.
Great. Okay, and this next question may be one that sits between yourself and Carsten Lott as it relates to the treatment of foreign body airway obstruction in pregnancy, and in particular the role of the abdominal thrust.
I'm happy to leave that to Carsten.
Hey, that's pretty nice. So we did not give any information or any suggestion to that. So I think this is a really complex combination. But nevertheless, if we go to the general recommendation in cardiac arrest and pregnancy, then it's we need to save the mother's life. And if we need to do that abdominal thrust, to get the foreign body out, to save the mother's life. So I personally feel we should go for it.
So
and I guess, yeah, if I could add, you know, the simple things like giving back blows and asking someone to cough, you know, if they're conscious, and you know, not forgetting the simple things first, if possible.
Sure.
Yeah, no, that's great. And I guess, you know, as people are reading through our guidelines and recommendations, you know, where there are gaps, where there are things where we haven't provided the guidance that you would look or would like to have as resuscitation practitioners, then do provide that provide that feedback to the European Resuscitation Council, so that we can take all of those sort of questions, you know, into consideration. And whilst there may not be evidence there that we can draw upon, what we can bring is the expertise of the writing groups to address and consider, and hopefully provide you with some help and guidance in some of these challenging areas. Okay, I'm very conscious of the time now. I think this this session is coming up to the hour. I think it's been a hugely engaging session. It's been great to hear from our 5 speakers and to see so much engagement from the hundreds of people that have joined this this particular presentation online. So before handing over to the conference scientific committee chair to close the session, I'd like to extend my thanks to you all as speakers for what really has been a truly engaging session. Thank you very much. Over to you, Jazz.
Thank you, Gavin. Thank you for all those who are listening. I'll give you the result of the adrenaline poll. So we had 625 people voting, of whom 52% said yes, we should keep it in the guidelines, 31% for non-shockable rhythms only, 10% didn't know, and 7% said no. So that's, you know, in line with the guidelines. But for that 48% of people who didn't want it in the guidelines or in some other form, please do feedback on the website and propose alternatives, and they'll all be considered. I'm going to thank the speakers, thank my co-chair. We're going to end the session. You need to go back onto the platform and look at what's coming up next. We have the Guidelines 2 session, there's some live industry sessions, and we also have some evening sessions, so lots of great content. The important thing is that when you stop this session, you click off this one, and then you have to join any other session starting afresh by clicking onto the program and onto the start for that session. Thank you all for listening.
Thank you.